So, continuing, we had sent our tandem mass spectrometry reports, and most of the metabolites were normal, although you could see that the
बढ़िया
methionine
बनेगी
levels were about low to normal,
बढ़िया
and
बनेगी
this would suggest a cause to repeat the test at a later date. The carnitine levels are also found to be close to low normal. So, due to our suspicion of homocystinemia, it would behoove us to go through why this would matter. So, the methylene tetrahydrofolate reductase catalyzes the reduction of the irreversible reduction of 510 methylene tetrahydrofolate to 5-methyl THF. And this would donate a methyl group to convert homocyst.
ये डिस्प्ले शेयर कर रहा है जिसमें ये पढ़
क्या 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 नोट्स बना रखे हैं
So the homocysteine would be converted to methionine, but then again, due to is this visible? Cysteine would be converted to methionine, and then the methionine is converted to S-adenosyl methionine, the adomate. That is the body's primary methyl group donor used in RNA and DNA methylation. So this SAM is metabolized back to homocysteine to complete the cycle. And homocysteine is important as it is a prothrombic factor, and that would be an that would be uh, a causative factor in neonatal stroke. So at this point, the possible etiology is difficult to delineate, and based on the initial workup, homocystinemia remains to be ruled out conclusively. We would anyways need to follow up at 3 to 6 months of age. Coming back to our case, we had stopped phenobarbital and started the baby on Levera with 20 milligram per kilo, and baby has been seizure free on Levera, and we had extubated the baby on day 6 of life and transitioned the baby from NG feeding to Parada feeding, and then direct breastfeeds were established on a day of life 9. And we had started the baby on vitamin B6 and B12 supplementation, suspecting homocystinemia and MTHFR gene mutations. As far as neurological examination was concerned, we had evaluated the baby, and the HNNE examination, at least the short version, was found to be normal, and you can see that examination, especially the U position and when we hold the baby by the shoulders, the tone appears now. The spontaneous movements of the baby are also appear more or less symmetrical, and there doesn't appear to be any facial asymmetry. And most importantly, Moro's was also symmetrical towards the time of discharge. Coming to the outcome, we had discharged the baby with multivitamin supplementation, especially B6 and B12, as well as folate supplementation. We had continued Levera at 30 milligram per kg as prophylactic uh, measure as per our pediatric neurologist advice. And we plan to send either whole exome or clinical exome on follow-up. So most common, the neonatal stroke, most of them, they present with convulsions. And it was found that in babies who have more than 10 episodes of seizures at the time of diagnosis, they had a risk of developing epileptic uh, syndromes, as well as in those babies who had strokes in multiple vessels, as well as stroke in the right middle cerebral artery territory. As far as prognosis, they found that the immature brain, especially in preterm baby strokes, there is a bit of compensation for early lesions, because they found that not all the children who had the structural involvement of visual pathway, they had not developed any abnormal visual function. Only half of the babies who had stroke involving the optic radiation had abnormal visual fields, and only 50% of the babies with parietal lobe lesions had fixation deficits in the first year of life. Management, mainly it is supportive management, and we need to give cardiopulmonary support, any inotropic support, and maintain hydration, and correct any dyslipidemias if present. The principal therapy, we need to treat the seizures promptly, as they may enhance the lesion and hemorrhagic transfer. And we also need to supplement vitamin K, which could prevent hemorrhagic transformation. Anticoagulant therapy is indicated to prevent recurrence of thrombus, as well as in any prothrombic states, to prevent embolism. AHA and chest guidelines recommend anticoagulation with low molecular weight heparin or unfractionated heparin only in prothrombotic states, or if you have any documented embolism or any congenital heart disease. This anticoagulants were not indicated in our case, as it was only an arterial vessel stroke, as well as we hadn't found any other vessels that had infarcts. And experimental treatments include hypothermia, which was found to reduce the incidence of convulsions in affected stroke babies. And they found that in rat models, the infarct size was decreased. And erythropoietin, we know about the neuroprotective effects and neurorestorative strategies. There's also many RCTs underway, and they found that in animal models, erythropoietin was given, and later the neuronal oligodendroglial precursors were increased, and astrocyte proliferation was reduced. Stem cell therapy, you can use multipotent stem cells as well as neural stem cells due to their anti-apoptotic anti-inflammatory activities. The feasibility of intranasal treatment of human newborns has been demonstrated, but we don't have any conclusive evidence. You can also derive multipotent stem cell derived exosomes. They promote neuroprotection as well as anti-inflammation neuronal repair.
Thank you, Dr. Shiva, for the nice presentation. Any questions?
So there are two questions in the group chat.
Arjun, can you please take those?
Yeah, I'll just read out the question. It was role of antiplatelet in your case or thrombolysis. So basically, we did not get any evidence of any actual, embolus or a thrombus in this case. Although there was features of infarct, it was more of looking like a vasculopathy uh, rather than an infarct, or I would say an embolus, because of which we didn't consider for thrombolysis. Second thing was we were worried and concerned about increase in the hemorrhagic extension if we start any thrombolysis in this baby, because of which we gave a consultation to a pediatric neurologist also, and he strongly advised against the use of thrombolysis because the initial picture of MRI was looking like as if it is a infarct. Along with that, there is surrounding hemorrhage also. So because of which we did not use thrombolysis. Plus, secondly, we did not have any evidence of prothrombotic state at that point of time. Plus, it was very difficult to diagnose also in the initial phase of life in the neonate till the baby is 3 months of old age. That's why after deciding accumulatively, we did not consider for thrombolysis in this baby. Any added view from you, sir, would be
No,
helpful.
Arjun, you are completely right because if we start thrombolysis, then the risk of intracranial hemorrhage is very high. And, and until we are definitely sure of a thrombus or embolism, we can't start with thrombolysis in therapy.
I think that answers our question. The question. There was one more question. I'll just see where it's on chat. Yeah, that's the same thrombolysis. The same question. Any other questions from anybody?
Okay, if there are no further questions, we are ending this meeting. Thank you for joining us. Thank you, Dr. Arjun. Thank you, Dr. Shiva. Thank you.
Thank you, sir. Thank you. Thank you, Shiva, for excellent presentation. Goodbye.